the next lecture we're going to talk about is quite a change from the exciting all-ceramic restoration. Removable partial dentures are the kind of restoration that most dentists are not overly excited about making. But what I try and get students to understand is that it serves a good function. Not everybody can can afford sophisticated fixed prostheses, implants. So a well-designed removable partial denture actually gives a lot of good value. So whether it replaces 2 teeth or 10 teeth, it's usually the same fee, and I communicate that to the patients. And when they understand that, it will give them a level of function, and it will give them a level of cosmesis, aesthetics, then it seems to be a more comfortable feeling for the patient. So the title is their role in prosthodontics, but it should really be their considerable role in prosthodontics. And what I touched on earlier is that while I'm at New York University, I'm not there full-time. So I'm considered a clinical full-time professor at New York University, but I'm also in private practice, and I'm also at 2 hospitals. And in the 2 hospitals, I treat a very unique variety of patients. So they're patients of a variety called maxillofacial prosthetics. So they can have a variety of congenital defects. It could be cleft palate. They could have acquired defects secondary to motor vehicle accidents, or more commonly cancer. So in that role, I teach at New York Hospital twice a month in the graduate program. And at Montefiore Medical Center, I actually direct the prosthodontic research there. And I have the appointment in medicine and in dentistry there. So at the Academy of Osseointegration meeting, which is an implant meeting, which is in the United States annually, I had the privilege of lecturing with a dental technician. So the technician that I lecture with, it's part of a team, and I can't emphasize that enough. In previous generations, there was a kind of dynamic that was unhealthy between the dentist and the technician. It was adversarial. The dentist would yell at the technician would yell back. What we kind of understand is that that's lose-lose for everybody. So you have to have a positive working relationship between the members of the team. And one of the common complaints that we have around the world is that this is a newspaper column from the Irish Times a couple of years ago. The perception of consumers is that they pay too much for dental services. But what is it that they're paying for, and what is their complaint? Because like I told you before, it's my experience that the ones that are satisfied, they don't run and tell everybody in their neighborhood that, oh, I love my dentist, he did a great filling, he did a great removable partial. It's the ones that complain that generate the dissatisfaction, because they are very noticeable. So when I touched on cast RPDs, when I say cast, there's essentially 2 types of removable partial dentures. One is an all acrylic, and we usually call them transitional or provisional, where we have some wrought clasps or sometimes prefabricated clasps, and they're less sturdy, and there's not much design. They're usually tissue-borne. When I talk about a cast RPD, I'm talking about something that's very specifically designed, that has rest seats and it has clasping mechanisms, and it can be a combination of tooth support and tissue support. And understanding some basic principles about removable partial denture therapy goes a long way, including patients who are going to have implant therapy, because patients who lose teeth are not going to walk around without teeth, so sometimes removable partial dentures are part of their treatment. So the fee schedule, what's the cost to the patient? I talked about 2 teeth or 10 teeth. That's impressive to some patients. They understand that this is something that, hey, if I can't afford to fix that tooth with a crown and I lose it, it's not going to cost me any more money to get the removable partial. It does have increased costs when fabricated in conjunction with crowns or implants. And I wrote a paper some years ago about this new type of removable denture patient. Some patients have spent a lot of money. They've gone to a dentist for 30 years. It's nobody's fault. They have a cycle of disease that's caries and perio, and they lose a lot of teeth. Although a lot of them have respect for that, they understand that it's not controlled. They've been seen by good clinicians, but unfortunately, as young dentists, you don't understand this. Dentistry fails. I don't care how good you are, but there are physiologic limits to crowns, bridges, dentures, etc. And there's lifespans of all these prostheses. And if you communicate that effectively to the patients, you don't have that problem where a patient's indignant that something broke after 3 years. If you tell them it's possible a clasp can break, but we can repair it. But if it breaks, it's, you have to pay to have the repair completed. You have 2 teeth remaining in the maxillary arch. There's minimal interocclusal space. So I like teeth. And in my undergraduate training, most clinicians would extract these 2 last teeth and make a complete denture. Except as a prosthodontist, I often get a patient pool that's a little bit higher dental IQ, and they may be resistant to something. Because unfortunately, there's a 5-letter word associated with loss of teeth. And it's a negative prognosticator. Does anybody know what the 5-letter word? They've done many psychological studies about, if you lose your teeth, what's the word most commonly associated with that? Anybody know? In Spanish, it's, I think it's 6 letters, muerte, dead. So they associate loss of teeth with death. So, this patient's in her late 70s. She doesn't want to lose these teeth. So we're going to do some crowns, and we're going to make her a cast RPD. So when you do combination prostheses, you can develop ideal everything. So the technician has to be on board from day one. If you're making 2 crowns and a cast RPD, they have to know that we want what? We want the occlusal rest seat designed a specific way. We want to have the undercut perfectly developed so that the clasp can snap in there and provide excellent retention in a patient that otherwise is heading for a complete denture. Okay? So if you look, there are some design elements here that are subtle but can extend the longevity. Everybody notice, we'll just go back one picture. There's limited interocclusal space here. So in my experience, I felt that I'd be worried about the patient breaking the denture base, okay? They bite into something and they crack off the teeth. So something that you can develop that costs a little bit more because it's not the exact simple cast partial is that the technician can be instructed to add this area here. Does everybody can see that? So it's essentially an extension of the major connector, and it's a metal stop. So that when the patient bites down, they're on cast metal. So for them to break cast metal, that's a cast base metal alloy. That's generating a lot of force. So I feel that those are the kind of subtle things that any one of you can incorporate and make a prosthesis more resistant to fracture and extend the longevity of the prosthesis. Now, some people philosophically, if you only have 2 teeth left in the maxilla, they would do a full palatal coverage. Okay, so in other words, the major connector would cover the whole palate to dissipate the occlusal forces. Of course, this particular patient had some experience with a provisional RPD, and that's why she came to me, because she didn't like something covering her whole palate. So you have to negotiate with the patient. We know that when the palate is open, they can taste better, or so they report to us subjectively. So advantages of this type of prosthesis, but we have to work with our technician because the dimensions have to be out of a textbook. So if a patient complains that it's too fat here and you go ahead and cut it back, you run the risk of what? Generating a sore spot. Have to be out of a textbook. So if a patient complains that it's too fat here and you go ahead and cut it back, you run the risk of what? Generating a sore spot. Because cast RPDs are generated with a relief area to seal them against the soft tissue, and they have to be of a dimension that will resist deformation. So, for example, a cast maxillary RPD, this is called an AP bar, this bar in the back has got to be 6 millimeters. That will give it resistance to deformation and will not allow it to torque and bend and distort over time. So what we're touching on are what kind of clasp we're going to use. What are the retentive components? So you have a cast circumferential clasp. Some people like an I-bar design. The major connector, is it full palatal coverage? Is it a horseshoe? Is it an AP bar? There's many different attributes of a prosthesis, but you have to describe them to the technician, or better yet, draw them. So if you send the cast with the drawing of what you want, the technician knows exactly what you want. When you do something like an occlusal stop, the question comes up, how do they know? Well, you have to send the denture tooth setup so the technician knows where to bring the stop, okay? And then, why keep teeth? Anybody know why we keep teeth? what's the word? I'm confused. Don't be with RPD design. You've seen this before. The reason why I keep the teeth is that you have proprioception. Okay, so proprioception can decelerate the mandible. So that's what we find with patients that have only implants. They don't know when to stop. So as their mandible starts to close, they're not getting any proprioceptive feedback from the alpha afferent fibers and the periodontal ligament to tell the brain to stop the jaw from closing so fast. And it also has discriminatory abilities. We know from a lot of different research that patients can discriminate different sized objects between their teeth better when they have some teeth. So if you do fixed removable prostheses, it's actually a dying art because it requires careful coordination between the technician and the dentist. So here's where we have a fixed partial denture on one side and a single crown and a fixed partial denture on the other side. So you have to tell the technician, we need a DO rest, we need a cingulum rest, we need mesial and distal guide planes, because you can develop guide planes with a surveyor perfectly on a cast because they can shave the wax and get it exactly parallel. And believe it or not, if you have very good guide planes, you need minimal retention. So guide planes, well designed, can keep the prosthesis up, even in a situation where you have gravity working against you. If you have a number of opposing guide planes, that prosthesis will stay in almost friction fit, okay? In a patient with complex three-dimensional asymmetries, this is how we can maybe address the problem with the removable component. Because this is a patient who has a large class 2 malocclusion. There's a huge span. The cuspids are in good shape, but this is just too big of a tooth span to do a fixed partial denture. And I told her that and explained that to her. Although resistant to removable, a positive prognosticator was 20 years before she had had a partial for a short period of time. So at least she knew what it meant. And at 70 years old, this is a patient who underwent orthognathic surgery to deal with other issues related to her treatment. When we look at the fixed removable conventional clasp design, it's very simple. So we have our guide planes here, it's slotted in, we have these clasps, and often I will try to develop more clasps because clasps can be removed. So I'd rather have too much retention than not enough retention. And then if there's an aesthetic issue, recently I just cut off one clasp for her. She had been wearing the partial for about 6 months, and she objected to the clasp, even though she had been told about it. I removed it, and it still has adequate retention. But if we look, I tried to show you where the discrepancy in the midline was. So here's a lateral, central, cuspid over here. She had cuspids, but it was such a huge space that I had to overlap, 2 teeth to get an aesthetic look for this patient. We're filling up a big space with a removable prosthesis where she did not want implant surgery, so the best option for her was in fact removable. So some people think that removable prostheses are second-class service. They're actually sometimes the best service you can give the patient because they will they'll preserve the most structures. They're less risk than a long-span fixed partial denture, and the design, the connectors, can actually dissipate occlusal forces. So well-designed removable prostheses, sometimes, like I said, is the first prosthesis of choice. So how can we promote growth in the field of removable partial dentures? Most people feel it's a dying art, and from the technical aspect it is. Casting a base metal, large, removable partial denture, it's so complex that I don't think they will be able to do this type of thing with a computer. I just think that the nuances of how you design a removable partial denture with the hard and soft tissue components, the retentive components, where you locate it on the tooth, I just think it is so very complex that I think that it is something that cannot be delegated to a computer. So, 2 implants are better than none. Sometimes patients come in and they can't afford extensive implant services, or they may not have enough bone without doing very invasive bone augmentation procedures. So as far as I'm concerned, 2 implants are better than none. So a patient comes in with a limited dental arch and only 1 cuspid. I consider someone missing a cuspid as having a major prosthetic challenge. The cuspid turns the arch. It has great periodontal support usually, and when they don't have one, the adjacent tooth, so a lateral incisor here, this is not a great tooth to clasp. It has limited root support, and my experience with clasping a mandibular lateral incisor is dismal. So a patient can have a couple of implants placed, and they can have something that they love, because usually they come in and they express dissatisfaction because they had a removable partial denture, distal extension, and they lost one of the retaining teeth. So patients begin to understand over time, especially if it's their second or their third partial, each partial, the number of natural teeth that remain becomes fewer, and the teeth on the partial becomes bigger. That's a basic concept that most patients can understand when you explain it to them. So what they love about this is what? There's no clasp. So when you have the advantage of, these are implants, and then this is a pre-machined component, it's called a locator. So there's several different companies that make different parts that screw in on top of an implant, and it helps you gain retention. You snap it in. Some patients have a desire for very high retention, and they have a different number of retentive males, color-coded, that you place into the prosthesis to afford them the retention that they want. The mistake that you'll make is they have implants, but the teeth are removable. So you have to tell them all removable prostheses move. So some move less than others, and if you increase the number of implants, you'll decrease the number of mobility. So once again, you have to have expertise in casting this type of prosthesis. This particular design is a lingual plate, so some patients don't have enough space between the attached tissue on the lingual and the tongue. Anybody know what the minimum number is? 6? Yeah, 7. So you need 3 millimeters from the gingival aspect or the lingual aspect of the mandibular teeth, and then 4 millimeters for the bar. So if you have less than that, you have to use a lingual plate as a major connector, and getting this type of casting back where it's accurately fitted is not easy. It's a difficult thing, especially a lot of times mandibular anterior teeth are crowded, the technician has to wax and block out, and it's very exacting and demanding. And here is the component that's used to give the retention to the prosthesis. Once again, now you would say to yourself, wow, this patient has a bunch of teeth. They have crowns. Increase support by design, especially if they don't want clasps. So some patients with a high smile line, despite the fact that they have adequate amounts of retaining teeth, they don't want clasps. So if you can design something with an implant bilaterally or unilaterally, where maybe you could decide to just clasp this and try and not clasp this and get the retention from the posterior teeth and the locator, it sometimes is very effective. So you have to decide before you start, where is the indirect retention? Where is the occlusal rest? Where are the clasping? So in this type of prosthesis, the patient's going to have improved function and aesthetics, but you can't guarantee that because some patients have unrealistic expectations, and they think that they're going to, they have a habit that they love to chew peanuts or who knows what, and they'll come into you and they'll tell you, gee, I spent this money, I had 2 implants, and now I can't chew whatever. So you have to warn them that there are limitations to all removable prostheses. They move, and we can't guarantee function. So how do we maximize, patient resources? Same thing. A patient like this, sometimes they have X dollars, but not XYZ dollars. So a patient like this sometimes can afford 3 implants and a removable prosthesis, and there's nothing that says that in 2 years, maybe they have more finances and they can add a couple of implants, you can eliminate the removable prosthesis. And it serves as a functional interim restoration until they have the resources to do something that's fixed and not removable. So you have to have the dentist work with the technician closely to supply these, and it's all about coordination. So you have to give them the design. You can't say, send me an RPD. That's irresponsible. You're a professional. If you write a prescription for an antibiotic or pain medicine to a pharmacist, it's no different. You have to write a prescription to the dental technician so that they know exactly what you want. Because if you send it without a prescription and something comes back that the patient doesn't like or you don't like, you have to pay him to make it again. It's not fair to expect that technician to do something for you for free if you trusted him to do it, in the first place. And that's where most of the arguments between dentists and technicians occur. So if you give them a master cast with a design, you tell them exactly what you want. In this particular instance, we made the impression at the level of the attachment. Some clinicians like to make an implant impression at the level of the implant and then later decide on which particular attachment they want to use. So when you do fixed removable, again, we have the guide planes, we have the rest seats, we have the major connector design. We can verify the seat of this on the cast and then go into the mouth and make a very stable interocclusal record to verify the tooth setup. So you have a stable record base. You then can do your trial denture tooth setup. When you do this, it facilitates the transfer of interocclusal records, so the technician's going to charge you if the bite, so to speak, is off. So if you don't make a correct interocclusal record and you're going to do a trial artificial tooth arrangement assessment and now it's off, now you have to take the teeth out and redo it, guess what? In the United States, they charge you for that step. If they do a setup and it's acceptable, terrific. If it's not acceptable and you're making them reset the teeth, you're going to pay for that. So it is beneficial for you to know how to reset a few teeth, because sometimes you can just pop off the posterior teeth here, get a new record, remount it yourself, and reset the teeth, try it in, and verify the patient accepts it, and then go to finish. So understand the dynamics and how important it is to work with the technician. So when you have this unique design, you have both tooth stabilization and retention from the implants. So as I spoke of previously, if this patient acquires some more finances and desires a fixed prosthesis, if you've planned this well, you can add some implants here, and then you'll be able to make a fixed prosthesis, fabricate a fixed prosthesis for that patient. And patient satisfaction counts. It counts in a dental school and it counts in your private office. And this is actually a very nice paper to review. It's from New York University. Dr. Chikanoff is now on faculty, as is Dr. Doan, but he did most of these principles when he was a resident in training. So as a instructor, as an educator, sometimes good students make a world of difference. They motivate the clinician, educator, to really think and rethink new concepts. And this is from the Journal of Prosthodontics of a year ago. So when we have removable partial overdentures, they're by design, not default. So sometimes patients are trying to have fixed prostheses on teeth or implants, and even in the provisional phase, you realize it's not going to work. So when do you reevaluate that? And this is a paper from an implant journal that it's not acceptable for some to have removable prosthesis, and that's a bias of the dentist. The patient sometimes doesn't know. Don't prejudice them by saying removable prostheses won't satisfy your needs, because sometimes the aesthetics and the function are perfectly adequate. And this is a paper that kind of touches on the concepts, and these concepts were expanded by Dr. Chikanoff's paper. So you have a mutilated dentition. I want to just review a couple of patient treatments. Sometimes edentulating a patient, taking their teeth out, is the easy way, because sometimes they come in with such a challenging assortment of mutilated dentition. Where are the teeth? Where is the occlusal plane? Where do you start? So you have to do proper diagnostics to facilitate removable design. So when this patient smiles, if you look at him closely, that's not his upper teeth, those are his lower teeth. Okay, so he's got a complex pattern of missing teeth, and how are we going to satisfy his aesthetic demands? And he has functional demands, and if you look at him, this is a gentleman who's going to generate a lot of force. He has a low Frankfurt mandibular angle. He's a square-jawed individual, and he has, the American College of Prosthodontics would classify this as ACP type 4, the hardest type of partial edentulosum to treat. And also the challenge, he has limited finances. So here's where removable partial dentures can afford a lot of good alternative treatment for him. And when we look at these pictures initially, you're like, well, this looks pretty straightforward. Here's the maxillary arch, here's the mandibular arch, what's the problem? The problem is when he closes, there's no room for anything, okay? So if we look, there's a lot of extrusion on both sides of his arch. So there's no room if you're going to do what's called conformative treatment. So in this type of treatment, the challenge is where do you set the pin on the articulator, because there's no room to restore, and you have to assess, can you restore some vertical dimension of occlusion here, and how much? So the first step is you mount casts, just like you do in an undergraduate clinic or in a graduate clinic. This is an absolutely required step, because then you can assess, on the cast when the patient's not here, where do we have the room deficiencies? And then how do we account for getting a record at where we think the patient should go? So very simply, a student made a vacuform, and we put some wax on it, and this allowed us to kind of get an idea of, if we're going to put teeth in his mouth, where do we need to be? So one of the basic functions in prosthodontics is to establish a plane of occlusion. And the plane of occlusion is dictated by a number of things. There's limitations. So you may have to increase the patient an unacceptable amount of vertical dimension, because the limitations are essentially phonetics and aesthetics. So if you open the vertical dimension and they can't speak or phonate properly, then you're not going to be able to restore the patient. So this is where we decided, we evaluated his vertical dimension of rest and his MIP position, and we felt that we can make a considerable change, and the pin is going to be opened on the articulator this amount. So it's a fairly dramatic amount, because we're going to have to compensate for a very large distance here. How are we going to do that? So a concept that can happen is we can overlay existing teeth. So how do we make teeth bigger? Well, we know how to make a tooth bigger. If it's this big and it's worn, we make a crown and we make it this big. But removable prostheses can also do that exact function. So in removable prostheses, we can make an overdenture component in a conventional removable partial denture. The question is, you have to have some ideas of concepts. If we think about resilient versus rigid clasping mechanisms, the posterior clasp on the molar is a cast circumferential clasp. It's half round and it's rigid, okay? This patient, we weren't sure, we didn't want to put a lot of physiologic function on the cuspids, so in theory, if we use a round wire on the anterior tooth, we may have a better biomechanical situation, because we would not want to lose one of our cuspids, which is a cornerstone of the RPOD. And this is a step that a lot of dentists are not acquainted with. So you make the impression, you send it to the laboratory. How do you make this complex casting? So it's no different than making a cast crown. So as we talked about earlier, this is the kind of thing that I don't think a computer can be taught to do without a lot of labor on behalf of the programmer. So someone's going to have to show the computer, where do we put this wax, where do we put this rest seat, where do we put this clasp, where do we engage the undercut. So this is called a refractory cast. So essentially, when you make the impression for a removable partial denture, the technician then has a number of steps to do before he can make that casting. And one of the steps that he does is what's called block out, and another step that he does is he waxes up the exact design of the cast on the cast, and hopefully you gave them a design cast so that he knows exactly where you want the components of the removable partial denture. Again, a sophisticated, looks simple, but it's actually going to wind up to be quite complex. We have three retentive elements, but we have to decide in which arch are we going to add tooth structure, because we have a big gap in the posterior mandible of where is the occlusal plane. So once again, if we analyze on the cast an initial wax up of, this is the occlusal plane discrepancy. So if we're putting most of the change in the vertical dimension in the maxillary arch, what are we doing in the mandibular arch? So if we look at this, the right side seems to be pretty good. Here's a cuspid, here's some teeth, this seems okay. But I think we'd all agree that this is now too high on the left side. So we can then, in the wax stage, remove some wax and get a more favorable plane of occlusion. So though the plane of occlusion is dictated by aesthetics of the maxillary arch, in the mandibular arch, you have to understand that there's limits to how high you can build teeth because there's a function of the tongue called transport. So if you build teeth above the plane of where the tongue likes to wag back and forth, you're going to have a problem moving the food back as you chew, and deglutition becomes very complicated because you have to organize that volume of food that's about to be swallowed, and the tongue is an integral part of that. Because if you get in the way of the tongue, something happens. It gets bit by the teeth. So patients don't like their teeth occluding with things other than food. So remember, sometimes in your artificial tooth arrangement, you don't have enough three-dimensional overlap, or it's deficient, it's closer to edge posteriorly. So the patient will report, I'm biting my cheek, I'm biting my tongue. So if it's only once or twice in a week since they had the prosthesis, that they'll probably accommodate to. If they're biting their cheek or their tongue or their lip, 6 times a day, that means that there's a problem with the artificial tooth arrangement, and you're going to have to address that. And hopefully it's something that you can modify with the acrylic denture teeth as opposed to remaking the prosthesis. So the way you do that is we're going to add some height to the cuspid on each side, raise the teeth a little bit in the mandibular arch, and then re-wax our overlay. So what we're doing here requires a lot of technical support by the laboratory. We're going to make a casting, inexpensive casting, at a base metal alloy. So we're going to use chrome cobalt to go over these teeth, but these are not crowns. They're essentially overlays that are going to be connected to the partial denture. So this is a cost-effective approach because the patient's not paying for fixed crowns or fixed onlays. We're going to incorporate this aspect of the prosthesis into the removable. So again, this requires very close laboratory support, and it's facilitated by a wonderful invention, the laser, okay? So conventionally, we know that if we have to section a fixed partial denture, we will solder the two pieces together, and that requires a laboratory event that you're melting something that melts at a lower melting point than the casting. Except that when that solder cools, there's a three-dimensional warping, and it's very hard to restrict that, and sometimes you have to do multiple solder joints. So the advantage of this type of technology is that you can actually laser weld this posterior portion to the framework. So the maxillary arch is very straightforward. You're all capable of designing this type of prosthesis, and you've described the patients like the open palate. When you do this, you have to have a posterior bar, because if you do a horseshoe shape, it interferes somewhat with speech. So if the patient objects to this back end of the bar, you have to understand that if you made a horseshoe-shaped major connector, it's got to be thicker for the to give it a resistance to any kind of damage during occlusion. So if the major connector is too thin and is not rigid enough, there'll be problems with the prosthesis. And another way, if you have someone who doesn't have experience with removable partial denture, you can make a very inexpensive impression and just make them something like an orthodontic retainer. Because if they're a gagger or something, or they don't like something on the roof of their mouth, or they don't know what that means, very quickly with autopolymerizing resin or with a triad-type material, you can make something that covers their palate, and they can wear it for a few days, and they can report back to you whether they can tolerate it. So this is the part of the removable partial denture that's been laser welded. This is a combination of a casting. This is also a characterized, this is not a mistake on the resident's part. Believe it or not, crooked teeth look natural. So believe it or not, as long as you get the patient's approval and they understand, gee, my teeth were always crooked, I like my crooked teeth, can I have the teeth crooked in the fixed or removal? I find that I've done some fixed prostheses where I asked for the technician to make the pontics crooked, and they don't understand that because it's something that defies their understanding of what something should look like. So you have to be very careful when you describe to the technician, hey, he had crooked teeth, she had crooked teeth, they like crooked teeth, please make the prosthesis with crooked teeth. So it is somewhat demanding to fit this type of structure. because this base metal alloy does not cast as well as a gold alloy, but with some, you fit it like any other prosthesis. If there's any high spots internally, you remove them. There's a material called Fit Check. It's somewhat expensive, but if you see a binding spot, you can go ahead and relieve that to verify the complete seating of the prosthesis. And I've done some research in laser treatments. Sometimes there's a question of penetration of the weld. So it is also evolving technology, but I think it's something that is going to have great application in the future. The prosthesis delivery and follow-up. If we're overlaying teeth, then we have a concern about plaque accumulation and caries. So anytime I do an overdenture of any sort, whether it's on top of teeth or on top of roots, the patient has to have aftercare. And the aftercare consists of, in the United States, writing a prescription for a fluoride gel, okay? So if we use sodium fluoride, it's a neutral fluoride gel. From many studies, we know that it will diminish the activity of the microbes causing the caries. So there's two types of microbes implicated in most caries situations. We know them all, right? You know what they are? Anybody know? What causes the caries? One of the prosthodontic residents? Want to choke out one of those little bug things you took in microbiology? Yeah, so strep mutans. Okay, so there's no trick questions here. So strep mutans is what causes caries. Lactobacilli are implicated in root caries. So it's a very interesting phenomenon. The root caries are very challenging to restore. Unfortunately, I treat a fair amount of patients that have had radiation therapy, and in addition to the root caries, they have trismus, they can't open well, they can't brush well, and trying to restore those patients is very challenging. So this is what the prosthesis looks like, maxillary RPD, and in the mandible we see the removable partial overdenture. And so what I'm trying to say is that, a patient who, this is a negative prognosticator. If a patient on initial therapy and presentation, you ask them to smile, this is not a typical smile, okay? This is not a normal or a natural smile. And this is what they do. They do an affected smile. They don't know how to smile. They're embarrassed to smile. And most times they do what? They cover their mouth when they smile. So once someone covers their mouth when you first meet them, it means that there's a psychological component to their communicating with you. So be very aware of someone who does not give a normal response to a smile prompt. And certainly this is adequate aesthetic treatment. He was very pleased. Did he require some adjustments? Yes. All removable prostheses have a time period of accommodation. They're going to get some sores, but this was mostly a tooth retained prosthesis, and it was very effective, and it gave him function and aesthetics. And when I was delighted to be part of this patient's treatment. It was accomplished by one of the residents at New York University College of Dentistry, Dr. Bellinger from Panama, a neighbor. So one of the things that I try to address as a maxillofacial prosthodontist, I try to get dentists to understand the unique patient pool and the privilege it is to offer these patients some type of treatment where it requires a lot of team treatment, not just the technician and the dentist, but we have to call in all of our other specialty colleagues to try and give this patient something that we feel is going to be predictable and last, a lifetime. Because adolescent patients can present to me, and sometimes children patients present to me suffering with ectodermal dysplasia. I'm not quite sure of the incidence of ectodermal dysplasia in Guatemala, but essentially it's going to happen, and it's going to have different degrees of expression. So ectodermal dysplasia is a disturbance of the ectoderm. So the patient's hair, nails, and teeth can be affected. And sometimes they have no teeth, and sometimes they have, compromised nails, sometimes they have no hair, or any combination thereof. So this patient has more expression of less hair, but he actually has a fair amount of teeth, and we're going to go through this. So he comes in for treatment, and, a dentist in his neighborhood, he's an adolescent, he's about 14 or 15 when he first comes in, and what they did is they bonded the teeth, okay? So most times there's a development of the tooth that is atypical for most syndromes, but in ectodermal dysplasia, the tooth is actually looks like an ice cream cone, okay? It has developed the enamel properly, but it does not have the morphological shape correct. So someone, bonded the teeth to give him some level of cosmesis, but it took a lot of coaching for him to give us this smile. So when he comes in, he has, some primary teeth with no subcutaneous teeth in the maxillary arch, and it's not uncommon to have just a couple of molars or a couple of cuspids. So there's varying degrees of missing teeth. So essentially, it's hypodontia. Hypodontia can be as few as one. It could be just a maxillary lateral incisor in a patient. Then there's oligodontia, which is many missing teeth. And essentially, this is what he has. So when we take the panoramic radiograph, we're diagnosing greater than 6 missing teeth. He's oligodontia. So where do we begin this complex treatment? And like anything else in dentistry, if you look carefully at the radiograph, this is all the bonding that's on the tooth, okay? These are the primary retained molars. There is no subcutaneous teeth. This is all he's getting, all right? When we strip off the bonding, this is very typical expression of these, Dracula-like vampire teeth. And, it's just something to describe to you, but the patients are very, very upset that they're not like their normal brother or sister. And this is an X-linked issue, so there's more males that come in and present with this than females. But we start with anything else. Anything complex in dentistry starts with diagnostic casts, because that's how you can communicate with each other. And when I say with each other, I'm talking about the dental team that you have to assemble to give this patient what you hope to be is ideal, definitive care, because you're looking at a lifetime ahead of them. So the first step you're all capable of doing, it becomes an issue of vertical dimension. Where are we going to put the teeth? So the teeth are in the way, but they're teeth. So some centers feel that the effort involved in doing orthodontics, etc., is not worth it. Maybe you should take the teeth out or go over them, etc. But with careful planning between, the orthodontist, we can convey to the orthodontist, these are very widely spaced teeth. And my bias in prosthodontics is that if I have central incisors, I want the orthodontist to move them to the central position. If I have lateral incisors, I want them in the lateral position. So I don't like to move a cuspid into a lateral position. It's just a bias on my part, okay? But the way we can do this is that we can get a vacuum form of where we want the teeth, and then we tell the orthodontist, gee, can you please move these teeth where I want them? And they said, that's terrific, Dr. Kurtz, but how do you know that these teeth are going to, your final prosthetic teeth are going to be there? I said, I don't know that, because this is a work in progress, because if you look, this is a complicated situation where they're going to want to try and do a little bit of intrusion. They want to do some tooth movements, mesially and distally. So we don't know where is the final prosthesis going to wind up. And in this initial setup, I felt for sure he'd be class 3. Because if you look, this is a very large lump of wax in the anterior mandible. So for my initial diagnosis and treatment, I'm pushing forward with putting most of the change in the patient's vertical dimension of occlusion in the mandibular arch. So these are very difficult concepts. I find that the concept most difficult to communicate with dental students and prosthodontic residents is vertical dimension, because we don't know. We don't know what a growing child, what his vertical dimension is. Should we project that he's going to be bigger at 18? Is he finished with his skeletal growth? These are all complex questions, and there unfortunately are no static answers. But essentially, as you move along, you get a better idea for how is the treatment proceeding. So again, the orthodontist, we've been telling them with casts, we want this tooth moved up if you can, we want these tooth consolidated. Here's every month they're checking this. At one point, there's a new innovation in anchorage. They were thinking about putting small implants in to help move the treatment along, because they can get better anchorage and pull those teeth and move them quicker. But essentially, we opted out of that. It was a surgical intervention, and we just proceeded with conventional orthodontics. In the mandibular arch, it was quite a debate, because in some circles, this is considered very aggressive treatment. Patient had ectopically erupting cuspids, and to move them into position would require a lot of effort, and there's limits to what orthodontics can do. So after careful consideration between the oral surgery department, the periodontic department, everybody. We felt that we would sacrifice, two of the teeth because part of the problems with patients that don't develop teeth is that they don't have alveolar bone. So when they don't have alveolar bone, there's the morbidity of creating bone. So a lot of times you have to take bone, and sometimes we do, from remote sites. So there's morbidity of doing a iliac crest graft, bringing it into the surgical field. There's the complications of not having enough soft tissue to cover the graft. So onlay grafting, it's fraught with issues, and we have a minor. So in the United States, this gets very complicated because of medical legal issues. We have a minor who the care has to go through the parent, and the parent actually wants more treatment than the child does. So essentially we had to get permission, we had to explain to the patient why we wanted to take the tooth out because it didn't hurt him. And then, if he said no, I told the mother, we cannot proceed because he's part of this equation. So after we explained this, he thought about it. We didn't tell him he had to make a decision because I said it's a while off. We have to do other treatment. But he finally did agree, and so did the mother, to proceed with this. Because in the United States, we have to get permission to treat in the dental school as well as in private practice. So if we look, it's starting to make some sense now. Because what we did is we were able to make a straightforward mandibular complete overdenture. We overlaid these molars, okay? And now the orthodontist is beginning to understand what we're trying to accomplish because he's working now against the plane of occlusion. So once he did that, he's feeling better. And we've had some three-dimensional eruption here. They've managed to intrude the teeth. So we set up a plane of occlusion. We did not know if the orthodontist could achieve it, but with hard work and diligent care on the faculty and the students' part, we were able to move, in the direction that we wanted to. So this is essentially the removal partial overdenture. So again, we're going to have a partial overdenture in the mandibular arch, and then we're going to have a maxillary overdenture to replace those missing teeth. So some may say, how do you know you can place implants in the mandible? Okay, is the child's going to grow? Are they going to move, etc.? Fortunately, in my center, we've done a fair amount of implant treatment of very young ectodermal dysplasia patients. And in the symphysis, the mandible grows down and forward. Now, in the maxillary arch, there's three-dimensional growth, so I would not recommend implant therapy before the age of 18 in a male and probably maybe 17 in a female to accomplish any of those goals, because there's three-dimensional eruption of the alveolus around the implants that leads to some complications. So if you look, this is the only area that we could put an implant without grafting. If you look at how thin this plate of bone is, it's not amenable to a ridge split. There is no alveolus. There was no alveolar bone. It's all basal bone. There was never any teeth. So if we look, you've seen this before. It's a very simple. Everyone here is capable of doing this. An implant is placed. There's a part that goes into the implant, and essentially you make snap-on teeth. And the teeth snap on, and there's different amounts of retention we can put in here. This is just acrylic processed over some chrome cobalt. And it gives a tooth form to the patient, but it goes over the existing height of the mandibular molar. But once again, now it's starting to make sense to us because the orthodontics is being completed, and now it's turning into prosthodontics. So from the initial registration, we're now having the laboratory make, these are provisional crowns and a provisional partial denture. So as we look, we see that we're at class 3. So I wasn't quite sure if we can give this patient a less class 3 appearance, but I said the time to try is in the provisionals. So we have these conically shaped teeth that require minimal preparation, and we're going to go ahead and install the patient's provisional crowns. So if you make laboratory temporary crowns, so these are acrylic crowns made in a laboratory to a specified dimension. Seating them all three-dimensionally when there's no adjacent teeth can be challenging. So essentially what we did is we made a vacuum form, and then we poked some holes in the temporary crowns because we want to make sure they seat three-dimensionally in an appropriate fashion. Part of the problems with relining, it looks easier. Oh, the lab made the temps, it's going to take me no time. Lab provisionals often take much more time to seat properly because there's some guesswork involved, because you may or may not prepare the tooth, and you have to align them three-dimensionally. So if you just make a vacuform, and then you can put your acrylic in here and seat them three-dimensionally, you're going to get to the end point that you want. We want to have some level of cosmesis for this patient. We want him to be able to smile readily to the smile prompt, and we want him to have an acceptable plane of occlusion. We want him to have subjectively an acceptable level of function. So we're on the right track. We have a lower plane of occlusion. We've got something in the provisional that we're not quite happy with. We're open, on one side. This plane of occlusion with the lower prosthesis is a little bit off, but that's what's wonderful about acrylic. So acrylic can be readily modified and polished, and you can modify at this point still, even though you have a definitive prosthesis in the mandibular arch, you can still get this plane of occlusion more acceptable. Then, it became an issue for the kid. Sometimes children don't speak, they don't communicate, they're intimidated, they're in with adults, but this is a child who was under a lot of dental care, so he was finally opening up to us, and I was delighted one day when he said, "I hate this hook," the clasp. I said, "Great, because this is a provisional prosthesis. In the final, we're not going to have that because you don't want it." So when you treat a child, if you could communicate to them that they have control, like I told him, he didn't need to have the teeth taken out, he didn't need to have implants. So it becomes a good psychological thing that the child is involved in the levels of care that you're providing them. It's also an ethical thing that you have to do. So here's the big question for the day. This is all enamel, and I want to do minimal tooth preparation, and I want to do all ceramic crowns. Actually, this is one of the residents who's going to do this. What type of all ceramic crown am I going to use? This is your big moment. All ceramic crown. Yes! Very good. Excellent. Very good answer. So she said Empress crown, because I have all enamel. I'm going to get a great bond of that Empress. This is not a patient. This is not a high-stress area. And we're going to have superior aesthetics, okay, for this type of prosthesis. And if you look, it gets a little complicated because in here is the patient's removable partial denture. So in one shot, we're making the impression of the final crowns, but with the patient's partial in the cast, okay? So then that day we have to pour the cast, Pindex the cast, and mount it because we have to give the patient back his prosthesis. But it's the only way to do it. It's otherwise too arbitrary and too complicated. So having some, laboratory skills in prosthodontics is a great assist for this type of treatment that you're providing the patient. Here we go. Here's where you can start to understand and appreciate the three-dimensionality of what we're trying to do here. Here we've got some ideal articulation here. Here we have acceptable but not ideal articulation here. But here we have primary teeth that are ankylosed. They're not going to erupt, but they're teeth, and I feel that they're going to afford us some period of time to support the prosthesis. So a primary tooth that's retained doesn't always have to be extracted, okay? And we don't know why they ankylose. Some people feel that they're not in function as the teeth erupt around them. That's why they don't erupt. But sometimes without subcutaneous teeth, these teeth do erupt. So it's not predictable. But once again, if we look at what are we designing here, we want something with a minimal palatal coverage. He didn't say that he didn't like the full palatal coverage because I joke with him. The advantage of the temporary prosthesis was that he would never burn his mouth on pizza, because as he bites into the pizza, he's covered with the palate. Whereas something like this, he's going to have the advantage of, we think, tasting the food better, perhaps. So if you look at the design, because we have distal guide planes on this partial denture here, we can generate a lot of resistance to movement. And if we have a mesial guide plane here, a distal guide plane here, and mesial guide planes on these teeth, we can generate a lot of friction fit. That's the best way to describe guide planes. They provide stability without clasping, okay? So with the RPOD, we're overlaying the primary molar teeth, and the posterior retentive elements and the anterior guide planes actually provide excellent retention for this. However, the orthodontists in the audience should notice something. So if you look, the teeth have been moved, and there was really no retentive component made for the teeth, okay? So the teeth have memory, and they like to go from whence they came. So early on, when we first delivered the prosthesis, we had a little bit of a gap here. except that I just wanted the patient to get used to the prosthesis, and you can cheat. So you can physically, this is less than a millimeter. So if we add a little bit of acrylic on each side to the, what are the cuspid teeth, you can actually just push the arch together mechanically. He didn't complain about it because first I compressed it with my fingers to move the whole arch together. He didn't say ouch, so I knew I could probably do it. Then you have to let the acrylic set outside the mouth, make sure it seats, then do the other side, make sure it seats, and then you can compress the entire arch back together and close the diastema. So if we look again, posteriorly, the final rehabilitation, we have adequate retention. We have non-ideal three-dimensional parameters because he's still growing. Okay, at this point he's 16 now. We'll check him every 6 months. If anything needs to be adjusted or accommodated, we'll take care of that. And unfortunately, I don't have Dr. Popper, who just did this treatment, just graduated, and she did not provide me with the final pictures. But I can assure you that this diastema is closed, and we've accomplished something that, you know, he smiles more readily. Do the teeth fit his face? Some patients can get away with what we call dominant central, and he's a growing guy. He's over 6 foot now, so he can get away with, you know, what we call a toothy smile. Not everybody can get away with that. So if someone's very petite and you have very large central incisors, it's not going to look right. Though we had limited choices where if we're going to retain those teeth, we have to have room for restorative material, and we can't get the crowns one on top of the other. So those are my principles, and if you don't like them, I have others. That's a joke. So muy comico. It's Groucho Marx. He's a famous American comedian. This is the Academy meeting that I told you about. It's every December. If you have any wish to come to a meeting like that, it's a nice time to visit New York. It's the holiday time. And thank you again. And before I showed you this picture, but I did not show you my badge here. So if you look closely at the badge, that's my brothel inspector. So again, that's a little comedy there. Anyway, thank you very much.